And our first talk, you can stay right here next to me, is by Kathryn LaRoche. She's Assistant Professor of Public Health at Purdue here. She's the recipient of a 2023 WGHI pilot grant, co-funded by our partners, the Indiana CTSI and the College of Health and Human Sciences. And she will talk about miscarriage care in Indiana in the midst of a shifting regulatory environment.
Hi. Thank you so much for the warm welcome. Hi, everyone. So my name is Kathryn LaRoche. I am in the Department of Public Health, and I am so excited to be here with you today. So as a little bit of background, approximately 20% of pregnancies in the US each year end in miscarriage, although in reality, this number is likely higher because many people might experience a miscarriage before they know that they are pregnant. We also know that although there are legal distinctions between miscarriage and abortion, they involve the same medications and procedures as a part of routine care. And so miscarriage is considered the spontaneous loss of a pregnancy, whereas abortion is terminating that pregnancy. But as I said, they use the same medications and procedures to manage these experiences. We also know that the terms that are used to talk about these two health issues are often conflated and confused. There is a lot of confusion. So, for example, the terms spontaneous abortion or missed abortion are clinical terms for miscarriage, and we often hear people talking about induced miscarriage as sometimes used to describe an abortion. Previous research in the United States has demonstrated that in settings like Catholic hospitals where abortion is not allowed, there are significant delays to people obtaining miscarriage care and sometimes even denied care for their miscarriage because clinicians lack clarity about the circumstances that would categorize it as either a miscarriage or an abortion. So when someone experiences a miscarriage, there's three possible treatment options. The first and probably the most common is called expectant management or watchful waiting. And this basically involves waiting for the body to pass the pregnancy tissue and products of conception on its own. We can also manage miscarriage with medication, so misoprostol and mifepristone, or with a surgical option through either a DNC or an aspiration procedure. It's important to note that many women and pregnant people can and do manage their miscarriage without medical intervention. However, we also know that retained products of conception can lead to infection and eventually sepsis. Indiana was the first state to move to ban abortion after the Supreme Court decision in Dobbs v. Jackson Women's Health Dobbs v. Jackson Women's Health case. The law was put in place and then enjoined for almost a year, and the prolonged enjoinment of the law meant that we're not able to compare participants' experiences obtaining miscarriage care before and after the implementation of that law in the same way that we had originally hoped to. But the fact that abortion is restricted and banned in almost all circumstances in Indiana is really important context for understanding our participants' experiences today. Beyond this, there is very little literature that focuses on people's experiences with miscarriage care in the United States. There are studies in the UK, in Canada, in Australia, in much of Europe that really do address this issue of what are women's experiences with miscarriage. But in the US, we see that the data is predominantly quantitative, and all of the qualitative data is focused on the experiences of clinicians providing care for this. So what this means is that although miscarriage is incredibly common, the voices of women and pregnant people who are most affected by this issue are absent in the literature, and we don't really know what's happening in the US. So the overarching aim of this study was to begin to address that gap, and also then, because we use an action-oriented approach, to develop strategies for improving the provision of miscarriage care and information across the state of Indiana. So we used community-based recruitment methods, including paper flyers and online posts. We shared word through community partners, and we posted on Instagram and Facebook. Then we conducted in-depth interviews with adults who had experienced a miscarriage in the last 5 years while they were living in Indiana. The interviews lasted an average of 90 minutes, between 60 and 90 minutes. Most of them were closer to 90, and we conducted them over the telephone or Zoom, depending on the participant's preference. Everyone received a $50 Amazon gift card as a thank you for their time, and we also linked participants who were interested with local resources and a non-judgmental toll-free phone line that offers support around all pregnancy options and experiences. We audio recorded the interviews, took notes throughout, engaged in a process of reflexive memoing, and ultimately carried out content and thematic analysis. So we spoke with 26 women in Indiana who ranged in age from 27 to 46 at the time of the interview. They reported on a total of 29 miscarriage experiences that had occurred in the last 5 years. The average was most people were around 8.5 or 9 weeks at the time that they experienced their pregnancy loss. Our sample was predominantly white, and I do want to address this because we made very concerted efforts to recruit women of color and non-English speakers. I have a really incredible team of students who are native Spanish speakers, and we tried very hard to recruit more non-white people. This is a limitation of this study and something that we're continuing to try and recruit for and hopefully capture the voices of more minoritized populations. However, we did have geographic diversity from across the state, and all of our participants use she, her pronouns. So participants described significant challenges in obtaining clear and actionable information regarding their miscarriage. All of the women that we spoke to were at least somewhat familiar with what we consider to be the basic signs of miscarriage, like vaginal bleeding and cramping, but they lacked knowledge about when to seek medical intervention or who to talk to, and the lack of clarity left many people feeling unsupported and uncertain. When women did try and reach out to a healthcare provider and ask for more information, they reported feeling shut down and brushed off. So Sophie, this was the case for Sophie. She was pregnant for the first time in 2021. Her and her husband were both very excited. This was a really deeply wanted pregnancy. And after she started bleeding at home, she said, I called my gynecology practice to see if there was anything that I could do. I said, I'm 8 weeks, and they just kind of laughed it off. They were like, well, unless you're 20 weeks, there's absolutely nothing we can do, so just go home and wait it out. But what about bleeding? What should I be expecting? What should I be looking for? And they didn't have a whole lot of information for me. So this is an example of Sophie who is trying to get information and is told, just wait it out, just go home. So like Sophie, many of the participants who we talked to interpreted this recommendation to wait it out as a dismissal of their concerns rather than a legitimate treatment option. So although watchful waiting can be medically appropriate, and indeed may have been medically appropriate for a lot of the people that we talked to, participants reported that providers often failed to explain the rationale or provide guidance on what to expect. So this intervention option was not watchful waiting, because with watchful waiting should come the idea that people have an idea of what they are waiting for or watching for, rather than just being sent home to wait it out. So Marissa experienced her miscarriage in 2023 and described it as almost a month of never knowing anything for sure and randomly just waiting to bleed out a bunch of tissue. Participants talked about how the instruction to wait it out was incongruent with the realities of their other responsibilities and commitments like work and childcare and wanting to have a life. A lot of women in our study shared stories of being embarrassed and humiliated because they were told to wait it out, and then they ended up bleeding or passing tissue in public spaces. So for example, a story of a woman talking about how she was out to lunch with her friends after she had already tried to go to the doctor. They didn't offer her anything, and she had a gush of blood and was really embarrassed about having to manage her miscarriage in a public bathroom. Other women talking about passing a lot of tissue while they're giving a presentation at work. So this advice to wait it out is not something that works for a lot of people. And even though we see that it might be, providers might think they're doing watchful waiting, that's not how the participants that were given these instructions were interpreting this information. So the lack of clarity about when and where to obtain care for miscarriage funneled women in our study to the emergency department. A number of the women in our study who were told to wait it out went to the emergency department because they desperately wanted information or recognition. They just didn't know what else to do. And so they went to the emergency department because they were turned away from the other places where they tried to ask for help or information. Other women in our study were told by healthcare providers that going to the emergency department was their only option. So Lauren had her miscarriage in 2022, and she told us, I called my gynecologist to see what are the next steps. What do I do? And they told me that I just had to go to the emergency room. There was no other option. They wouldn't see me. They just wanted me to go to the ER. I was honestly so mad. Is that all? I don't want that. And then many women in our study reported that when they ended up in the emergency department, not because they actually felt like they required emergent life-threatening care, but because there was a lack of information and resources for them and they did not know where else to go. Then, once they arrived at the ED, participants unanimously reflected on the experiences as negative, often costly, and in some cases traumatizing. So a few participants were set up with serial blood draws to track beta HCG levels. They were linked with care outside of the hospital, but this was the minority of participants and was more of an exceptional experience. Generally, participants reported that once they arrived at the ED, they were told to go home and consult with their OBGYN. But since many of the women ended up at the emergency department because they called their OBGYN, who then told them that the only thing they could do was go to the emergency department, this was immensely frustrating and confusing. And then when some of our participants received bills in the mail for thousands of dollars that they were not expecting, people talk about it as adding insult to injury because they did not reflect on the care that they received there as actually helping them. And then there's a confusion about what they have to pay for. And then as well, administrative burden, emotional burden of figuring out how are you going to challenge this charge? How are you going to call your insurance? Where are you going to come up with your money? And definitely talked with people in this study who talk about themselves as paycheckers to paycheckers and couldn't afford the emergency department bill that they got after they had a miscarriage and were told to go there by a gynecologist. So Shannon had her miscarriage in 2022, and she did go to the emergency department after she was recommended to go there. She said, I would have taken them up on something to induce it. When I first went in, they were just like, oh, you're through the worst of it. And I hadn't even started bleeding, really. So none of the women in our study who went to the emergency department actually required emergent medical care, but none of them were offered treatment options or information that they considered useful. None of them were given the option to facilitate the process of their pregnancy loss with either a medication or a procedural intervention. And that is before and after the abortion restrictions went into place across the state. So in our study, the only women who were offered an intervention for their pregnancy loss were those who discovered that they were experiencing a miscarriage in a healthcare setting. So they were at a prenatal appointment and the doctor told them that due to ultrasounds or other tests that they were doing, they broke the news to them that their pregnancy was no longer viable. Those people were offered an intervention, but for everyone who started bleeding at home, they were just told to go home and wait it out. All of our participants, except one who were offered an intervention, so either a medication or a procedure, opted to use it. The one woman who did not opt for an intervention later reflected on this decision as a mistake and explained that she didn't have enough information at the time to make an informed choice. She felt very pressured to move forward, and she was still coming to terms with the fact that she no longer had a viable but wanted pregnancy. So this also leads into another key finding, is that when participants are offered intervention or information about pregnancy loss, overwhelmingly they describe a lack of patient-centered care and processes. We heard a lot of stories about people at their OBs or in the ED, and this one, it's one of the ones that in particular really sticks out to me Angela was not the only person to report this, but while she was having a transvaginal ultrasound, such as an ultrasound wand, which was inserted inside of her, the OBGYN told her that she was having a miscarriage and immediately launched into treatment options while the ultrasound probe was still inside of her. So Angela said, when the transvaginal ultrasound is happening, the OB is talking about, you could take a pill or you can have a procedure. And I'm like, can you get this out of my vagina and let me think? Because she has just discovered that her deeply wanted pregnancy is no longer viable. And both she and her husband are dealing with the emotional fallout of this. So this is perhaps not the best time or the best way to share potential treatment options for people. And so Angela's story really highlights how that one participant who refused intervention but then later reflected on it, how you can see how it's very easy for her to make that decision to turn it down. So inconsistent with standards of care, not all of the participants who were offered options participants were not overwhelmingly not offered options to manage their pregnancy loss. It's important to remember that people have different preferences, needs, and desires for how to manage their care. So not everybody that has a miscarriage wants an intervention, but there are a lot of people who do or who would have wanted more information about what to expect that could have drastically altered their experience of care. The study shows us that improving care for pregnancy loss requires a multi-pronged approach. One of the first things that we really need to do is identify options for care outside of the ED. Please stop sending pregnant, bleeding people to the emergency department because in general, this is a very negative and traumatic experience. And we also need to improve the use of patient-centered approaches for pregnancy loss in the ED. So as a couple of next steps, I'm currently doing lunch and learn sessions and setting up lunch and learn sessions with emergency department physicians across the state where we're going to be sharing these research findings. I'm also working with some of my emergency department collaborators in Indianapolis to identify opportunities to implement patient-centered care for patients with vaginal bleeding and pregnancy loss in a more systematic way. And the other thing that we really need to do and are currently working on is identifying community-based avenues for sharing information and support that are not in the ED. So just want to give a really quick shout out to WGHI. Thank you so much for funding this project. I couldn't have done it without you. Thank you so much to all of the participants who shared their story with me. I don't take it lightly. And shout out to my incredible team of undergraduate and graduate students who are the light of my life and have made really incredible contributions to this project. Thank you.